needs urgent attention, not looking for the doctors, or rather the surgeons to perform the surgery. It has to be open 24 hours, 7 days a week. So part of knowledge development is we realized that the people who are serving in the casualty or emergency departments have no prior knowledge of emergencies that appear at their door. Given the case of Victor, who presented earlier, you realize the delays that were happening along the system. Yeah? From the point of emergency, getting transportation was an issue. Getting to a place where there was some bit of misdiagnosis, which again caused delay. Then the referral, again, there were delays. So part of the initiatives that we have is one, the Casualty app. You can all download the Casualty app. It's available on Google Play and iOS. So with the Casualty app, we provide emergency information for healthcare workers and first aid education for the lay public. Some of the courses that we offer are triage, ECG, point of care ultrasound, tech, airway and ventilation, CCT, which is primarily for the community health workers, training them to become lay first responders, emergency medical dispatchers, and emergency vehicle operators. All of you, in one way or another, your facilities have benefited from this. For capacity building, yes, that is an ED in Kenya, and the CC is in the room. Yes, that is an emergency department in Kenya. Siajiongelele? No. That's not Coast General. Yes, we have renovated Coast General. That's Nyeri County Referral Hospital. So part of what we call capacity building as an organization is looking at infrastructure. So infrastructure is looking at your ED and your capacities and seeing how we can improve your processes. We do not do brick and mortar. I will not come and set up a new building for you, but we work with the space provided. Under equip, any training we conduct, especially triage, ECG, POCAS, we provide equipment. So any triage training that has happened in any facility in your county, they're given a vital signs monitor. Any ECG training that has happened in a facility in your counties, they're given an ECG machine. Any point of care ultrasound training that has happened in your county, they're given a point of care ultrasound machine. We also install oxygen manifolds in emergency departments that do not have proper oxygen piping. The equipment we donate is to be used at the emergency department. Yes? Other departments may borrow, but its primary station is the emergency department. Because sometimes we find our POCAS machines in the maternity ward, yet you have a trauma case in the ED that requires the services. Adopt an ED is what now renovating the emergency department and improve them. Then we have ambulancy. Ambulancy is looking at your pre-hospital services and your coordination of emergency medical services. Research. Every intervention, every program we come up with is data-driven. Yes? I will not come to Elgeyo Marakwet and start asking Waziri here if, no, can we do 1, 2, 3? That is not data-driven. The interventions have to be data-driven. She always laughs because I always tell her, you have to show cause. Tell me why you need training. Tell me why you need to have a dispatch center. Tell me why you need additional ambulances, etc. So at the end of it, this is the framework. Your emergency medical services should look this way. Your community should be able to call for help. There should be proper transportation when getting to the facility, because also during transportation, they're being accorded care. Yeah? It's not like being in a tuk-tuk. Yeah? When you're transported properly in an ambulance, you're being accorded, with the proper personnel, you're being accorded care. Then we get to the facilities. The people at the facilities know what to do. We are no longer practicing the witchcraft of first come, first served. Triage has to happen. Sawa. So how do we engage with most of you or all of you? So the first step is looking at having your emergency medical care plan. So the emergency medical care plan picks, among other things, your infrastructure development, your service quality, your financing mechanisms, your human resource development, your monitoring and evaluation, and your leadership and governance. We'll hear from some of the counties that have actually completed the process on how that has enabled them to actually even budget for the emergency services along the way. The second step is your emergency medical services plan. So your emergency medical care plan is your mother document. And I put that in air quotes. Your emergency medical services plan is your pre-hospital, it looks at your pre-hospital services, yeah? Your ambulances, how is the community calling for help? Is there that one number? It looks at your ambulances. Do they meet, at bare minimum, the CAB standards in terms of equipment and in terms of personnel? How are emergencies being coordinated in your county? Do I need to call Dr. Ganda, who calls Sijui MedSoup? Who calls Sijui driver or ambulance? Who calls hospital administrator? Yeah? How is your system? The other is looking at the SOPs in terms of how is care being provided, and of course, resource allocation. Problem is if I ask most counties, when you tell me you have resource allocation for emergency care, most of the times it's fuel for ambulances. And that way you've covered everything, which is not the case. After you finished your emergency medical care, your emergency medical care plan and your emergency medical services plan, we help counties set up a dispatch center. There are a few of you in the room who have dispatch centers already. How many? Set up by us. Okay. How many have dispatch centers already? Yeah? Not a call center, a dispatch center. Of those dispatch centers, how many are operational 24/7? How many have centralized coordination in terms of any use of ambulance or any emergencies comes through the dispatch center? So even if I'm having a referral, it is an interfacility referral. To get to use the ambulance, they have to call the dispatch center. So 1, 2, 3. We'll explain. They're not the same. Okay. How many have an emergency number, an emergency access number that is known to the public, to their community? Okay. How many dispatch centers have what we call interagency collaboration? Case in point, if there's a mass casualty, a bus has crashed. You need to call the police, you need to call the fire department, you need to call maybe Ngao. How many in their dispatch centers can do that? 1, 2, 3, 4, 5. Okay. How many counties have GPS tracking in their ambulances? Installed, not working. Okay, I rephrase the question. How many counties have operational GPS tracking in their ambulances? 1, 2, 3. I like the numbers. In your call center, dispatch center, how many call centers or dispatch centers can pick multiple calls? 4. How many dispatch centers have dispatchers? Emergency medical dispatchers. EMDs. Trained. 2 or 3. Your ambulances, how many are driven by emergency vehicle operators? See driver 2. You can see the gaps. Tulianza na mikono mingi, lakini sasa, I'm being specific here because we have to be specific. So this is our work in progress. We've worked with all 47 of you. You're given the same plate in terms of resources. So here is where we are at. So Mombasa County both have an EMC plan and an EMS plan, and currently their dispatch center setup is ongoing. Kwale, they have an EMC plan. They've just finished their EMS plan, so we'll be setting up their dispatch center. So the counties in blue have completed most of the processes. The counties in black are ongoing. The counties in red, hatujaonana. Sindio? If you see yourself in red there, tuonane kando. So we'll have some brief discussions, and I would want your counterpart to actually share some of their experiences. I'll start with Kilifi County.
So thank you very much. In Kilifi, we have implemented this process, and it's been a learning journey because along the way there are challenges. It's not just smooth sailing. We started by developing the 2 plans, like she said, with the support of Emergency Medical Services, Medical Emergency Foundation Kenya. We advertised for the position of EMTs, went through the trainings. We went through the trainings to convert our drivers to ambulance operators. We worked very closely with St. John's Ambulance and the Emergency Care Foundation, and we set up a coordination unit. This is the Medical Emergency Services unit. We started with 20 ambulances, and I can say that one of the challenges is the varying levels of these ambulances, because our ambulances were old. I mean, they are old. So we bought only 4 new ambulances, the others were very old. We tried to rehabilitate them, quite a number, and we had 20 running. But because they are old, over time they have been, some of them, frequently break down. So thank God this financial year we have included a budget to sort of purchase additional ambulances so that we can be able to have the service going on. So we have the emergency call center. The vehicles are fitted with GPS. So the coordination of the ambulances is centralized. We have zoned the county, and each sub-county has the ambulances stationed there, but the coordination of the running of the ambulances is central. So the person at the call center, when you call, they look at the screens to find out where is the next available ambulance, so that ambulance then is directed to the place where the emergency is and the referral is done. However, there are still challenges. Like you say, the problem, if we want to set up this, the first thing that we need to think about is having adequate ambulances and proper ambulances. So that's an expense that we have to be ready, because even, just the other day we were reviewing in our own system and saying we really need to strengthen certain areas so that this, so we have a number. If you call it even right now, you'll get a response. The number is 1535, and it directs you to, if it is health emergency, you are directed now to the ambulances. If it is a fire, you are directed to the fire. And sometimes we also have the emergencies at sea because of, we are at the ocean. So we are able to, get the teams out there to be able to respond. We really appreciate the support. We also have had the trainings that she's talked about, so that we are very complete. So we started with 23 EMTs and turned our drivers, 30 of them, trained them in, so that they're now operators. The problem that we have, and this is something that you'll face a challenge with the Public Service Board, is where they place these people you call EMTs in the public service structure. So that is an ongoing discussion. We already have them. We put them in a contract. Of course, they want it to be turned into, PNP, which we have started the process of doing that. So in just the last 1 year, we've had over 3,000 evacuations using this system, coordinated centrally by this team. There are still challenges that, like I say, it's not perfect. So we really looking forward to improving on it. We're still getting the support from the emergency foundation team. Even this week, there was a training going on. We are also looking forward to making sure that we strengthen this. But we have a lesson. That's why I was saying that the team at SHA, we need to have a conversation, because we've gone through this for 2 years now. So we have some lessons that we can be able to share in terms of what to do and what not to do. But like I say, it's still not perfect, but it's work in progress. Thank you.
So I know I've been receiving a lot of questions on how to onboard EMTs. Maybe you can liaise with Waziri and figure out how he's been able to figure out his way around. Turkana County was actually the first county to complete the processes. So your lessons, Dr.
Thank you. I think basically my colleague from Kilifi has mentioned some of the aspects that we have also implemented, but I just mentioned a few. Because of the framework and the policy that we, Emergency Foundation helped us to come up with. Actually, we customized some of the things that were in the national policy, and these helped us to sort of ring-fence the budget for referrals. So currently, referral budget is not part of the shareable revenue. It is a first charge. So you see how the departments, usually they say salary, like that. So for us, referral is there as a budget that is ring-fenced. And that one is starting from this year. It's because of that policy. And also, we have been able to advertise for EMTs. And We are in the process of shortlisting now. And just to mention a few challenges that we have. The first challenge was, there was the misunderstanding of the call center. So our guys brought all the ambulances to Lodwar. So when I came to the office, we had a presentation actually from Ramka, one of the AMREF guys, because one of the causes of maternal mortalities was delayed referral, because we are sending ambulance from Lodwar to Kibish, which is 400 kilometers away, and the road is not good. But the reason why they were doing that was because of fuel. You know, that is the biggest challenge that ambulances have. You can have a very good operational call center, the dispatch center, but you will receive a call, but the ambulance does not have a fuel. So they kept on, the call said, the dispatch center kept on calling the chief officer calls me, so I tell him, where do you want me to get the fuel? So we had to make a decision, send all the ambulances to the sub-county hospitals, and instructed the sub-county hospital to use their share money to fuel the ambulances. So currently we are not receiving calls. At least things are moving. And this year now, because we have this budget, the plan is going to work very well, and we are going to have that conversation to ensure everything goes smoothly. So that is what we have achieved. Thank you so much.
Thank you, Dr.
Thank you, Emily. All protocols observed. Allow me to honor the presence of our peers in the room. For CIA, I've opted to stand here and not go there, because now I'm not just thumbing the military way. I want to be very humble. Now, for CIA, I'm so sad there is not even a picture for CIA. But I am just a living testimony of the good work from Emergency Medicine Kenya, what they have done for us. We have been walking this path of emergency care and ambulance service and referral for a long time. We have been working with the EMK, and they were supporting Sierra County in all those various ways, capacity building, training. They established our dispatch center over the periods. But 6 months back, or less, they put up one wonderful accident and emergency department worth over 20 M. And it's completed. We will be opening it, I promised, within 1 week or so. It is a 14-bed capacity. It has 3/4 of the services that were listed there. Triage, ECG, all that. They have equipped it. Actually, I took the Waziris to tour it as a preliminary before the governor opens it, and they thought it was like the standard of Aga Khan. And they were amazed. It has all the aspects. There is a minor operating theater there, and everybody is very elated. We will ensure that when it's opened, you will get communication. We are waiting for the governor. When he's ready, he has a busy schedule, he will open it. Generally speaking, here we have up to 14 ambulances. We have been collaborating with other emergency providers in addition to EMK. We do like over 2,700. That is just one component of the reproductive health elements. And we are actually on a lot of rise and increment as far as this is concerned. We believe that when we open this center, many of you will be hearing more about Siaya, not just politics. I want to take this opportunity also to mention that either yesterday or earlier on, I was chest stamping. This is not about EMK. I'm just pleading because the PS is here, PS, sir. In an earlier event, I talked about SHA registration, and I thought it would be done in a military way, and I explained. But now, I was humbling myself to mention that something arose here regarding land and title deed ownership of our facilities. I want to beg that if a decree can be passed from the higher offices, the way education did with their facilities, with their schools, it would really help many of us who have, like me, I have 176 facilities, only 10% have title deeds. I was requesting if it can be started from the top and a decree is passed, we could own these facilities, especially if proper inventory is taken and all the facilities without any squabbles, without any controversies, without any misunderstandings. Everything is correct. Nobody is claiming the land. And the government, plus the Ministry of Health, just decrees that we get the title deeds. Everything can be fast-tracked. I was just leaving testimony for the EMK. I'm sorry I brought in another foreign request, but it is because I humbled myself. Now I'm not militaristic. Thank you. Please remember these pleas I'm making, so that we push and we get even one.
So moving forward, we're still available to provide technical assistance in the development of your policies. We are still available to train more of your clinical staff in emergency medical care, donate more emergency medical care equipment, train your community health workers to become lay fast responders, and strengthen your emergency medical services system. And with that, nimefunga.
Thank you very much. I think she deserves another Nyayo clap. Let's clap for her. Moja, Billy, Funga, Fungua, Asante. Thank you very much. I would like to hand over this now to the chair. We thought we were going to have a plenary, but I can imagine I'm looking at the faces here. And the fact that there was the quote unquote E plus dinner. So I'm standing here between this session and dinner. So let me hand over to Greg to sort of wrap up this session so that then we